Hi, everyone. Welcome to our citywide psychiatry grand rounds. My name is Dr. Raj Rasasingham. I'm the Director of Continuing Professional and Practice Development. Welcome to this month's citywide psychiatry grand rounds. It's a great pleasure to do this grand rounds with Waypoint Center for Mental Health Care as our partner for today. Before we begin, I would like to do an online land acknowledgement. I would like to begin with an acknowledgement of the land on which we work, study, and live. Before I read it, I want to take a moment for you to situate yourself and think about the land under you and around you. We recognize that many Indigenous nations have long-standing relationships with territories which the sites of the Department of Psychiatry are located that precede the establishment of the University of Toronto. We acknowledge our presence on the traditional territory of many Indigenous nations, including the Mississaugas of the Credit, the Anishinaabe, and the Chippewa, and the Haudenosaunee and Wendat people. Today, this land is home to many diverse First Nations, Inuit, Métis people, and we're grateful to have the opportunity to live, work, and gather in these territories. We acknowledge that Toronto is covered by Treaty 13, signed with the Mississaugas of the Credit, and the Williams Treaty, signed with the multiple Mississauga and Chippewa bands. Since this event is a virtual gathering, a singular land acknowledgement does not capture the richness of our distribution across many locations. There are few places on earth that someone before us has not called home. So thank you for that. There will be an evaluation link sent to you to all the attendees after today's presentation, and your feedback is always appreciated. Our next citywide psychiatry grand rounds will be on March 31st, and that will be the Vivian Rakoff Memorial Election. Hope you'll join us for that. At this point, I would like to introduce the Vice President of Research and Academics and the Chief Scientific Officer at Waypoint. It's a great pleasure to introduce Dr. Bernard Lafoyle, who will introduce the speaker for today. So thank you.
Thank you, Raj. Hello, good afternoon. So I am Dr. Bernard Lafoyle. It's my pleasure today to introduce Dr. Zoe Hilton. So Dr. Hilton is a full professor in the department and is a senior scientist at the Waypoint Research Institute. So, Dr. Hilton.
Well, thank you for the introduction and thank you for the opportunity to speak to you today. Can everybody hear me okay and see my first slide okay?
Yes.
Thank you. And thank you everybody for taking the time out of your day to join me for this presentation. So in today's webinar, I'm going to provide an overview of the principles of effective correctional service as they relate to domestic violence or intimate partner violence. And this model is known by the first three principles, which are risk, need, and responsivity, where risk tells us who to treat, need tells us what to treat, and responsivity tells us how to treat. My learning objectives for today are that by the end of the webinar, you'll know how the RNR principles relate to domestic violence, especially in identifying treatment needs with a view to treatment planning. Now, I'll often use the phrase domestic violence, but in general, I mean this to include intimate partner violence or IPV, I'll also say. And my research with domestic violence started out originally with intimate partner violence in partners who were living together or had been living together or married at some point, but this has extended to include non-cohabiting violence as well between the partners. And so intimate partner violence is more of an inclusive term. So that's the way that I'll be using it. And I'm also, in a lot of the research that I'll share today, I'm referring to IPV by men against their female partners. And that's simply a reflection of how most of the research in this area has been focused on the men who perpetrate domestic violence. I have done some research with women who perpetrate domestic violence, but I won't be really speaking about that much today. And in addition, I'm currently working with a couple of teams that are looking at domestic violence and intimate partner violence and coercive control in gender diverse individuals, as well as part of a broader inclusive population. And I won't be speaking about that today either, but I'm happy to answer any questions about that. And I'm going to be sharing some of my research with, sorry about that. I'm going to be sharing some of my research about the ODAR. I'm an author of the ODAR, so that's part of my disclosure there at the bottom of the screen. And the ODAR is an empirical actuarial risk assessment for domestic violence recidivism that is these days quite widely used in policing and correctional services and some treatment services as well. So here I just want to give you the opportunity to say, if you can, pop something in the chat about how experienced are you with providing treatment for people who perpetrate IPV. Now, this could be none at all. It could be a little, it could be a lot. I keep pressing my keyboard, sorry. I'd like to get an idea if you could just put that in the chat. I should be able to see that as it pops up. And if you have experience with providing IPV treatment, what models of IPV treatment are you familiar with? I'm just going to take a quick look at the chat, and I see everything from none, a lot of none, to minimal or a lot. And I see some caring dads, that's great. And I see some reference to the Duluth model as well, or behavioral intervention. That's great. So we've got, I see somebody there who is a SANE, that's wonderful. Correctional Services Canada, that's wonderful. It's good to have you here, and the PARS as well. Okay, so for those of you who are experienced, a broad variety of programs that you've been involved with as well. Okay, so thank you for sharing that, and I'm glad you're here. So my next, now my screen chooses not to move. All right, here we are. So what I want to do here is just give you a brief overview of the history of domestic violence treatment. Some of you will be familiar with this. Some of you might see models that you recognize here. And I partly want to do this overview because I see many of you have no familiarity with it. And if you're coming from a forensic psychiatry background or other mental health background, it's maybe different from the kind of history of treatment that you might be used to. So the whole thing started, I would say, in the 1970s, out of what was called the battered women's movement. So the problem of what was called battered women was discovered partly from a psychiatric perspective, but also from the feminist perspective, which had a very strong voice at the time. And the feminist approach saw domestic violence perhaps quite legitimately, reasonably, as rooted in patriarchy and men's attitudes and differential of power and abuse in male-female relationships. And the grassroots of treatment at that time was focused on promoting victim safety and victim refuge and so on, but also for individuals who were perpetrating domestic violence, trying to change their patriarchal views, trying to change their attitudes towards women, their attitudes towards domestic violence in particular. And by the 1980s, the impetus for treatment was coming from more diverse perspectives. So a lot of the impetus was coming from the criminal justice system, and we're seeing court-mandated treatment, and we're seeing some program standards developed. This is more in the US than in Canada. And at this time, we're seeing the growth of programs and models like the Duluth model, which retains that feminist perspective and also uses a psychosocial model. It's developed and grown and changed over the years. And as well as providing individual treatment, the Duluth model is seeking to be part of a coordinated response to domestic violence. And from the 1990s, and I would say up to now, there has been more of an explosion in different approaches to domestic violence as the different, I guess, parties of interest have become involved and developed program. So here now we'll see more on cognitive behavioral therapy, CBT. We'll see parenting, and I heard somebody was here from Caring Dads program that seeks to help men who use domestic violence be better dads in that family role. A survey a few years ago in the USA found that there were over 1,500 different kinds of what was called battery intervention programs, or BIPs, in the US. Canada kind of came to the scene a little later, has developed the programs a little later, and so we see more, I think, multidisciplinary models in domestic violence treatment. And all over, we see some blurring of models sometimes, so a bit of CBT, a bit of psychoeducational, and so on. That's my reading of the literature. So I have not been an IPV treatment provider. So if I have this overview, if you see anything that's, that's not representing your understanding, I'm happy to hear from you in the Q&A as well. So what do we know about how well all this treatment has been working? I will say a couple things. One is, unfortunately, most treatment programs that are out there are not evaluated. And often when evaluations have been conducted, they're not using well-controlled designs. And reviews that have been conducted find, in addition to the weaknesses with the methodological approaches, the treatment effects tend to be very small and sometimes not significant. So this slide shows results from one of the comparisons that was done in a meta-analysis in 2005. What it shows is an overall, if you look at the overall mean D at the bottom, the overall effect is not significant because it's crossing that 0 line, and it's very small. It's like 0.1 or something there. And there have been similar reviews before or since that have found similar small or null effects. Now, if the comparison group includes treatment dropouts, then the treatment effect looks more favorable, but in more controlled studies, haven't been in the past getting great overall results. But now I'm going to say this is before researchers and practitioners started to look at the RNR principles in domestic violence treatment and calling for treatment to learn from the general correctional treatment literature and apply that to domestic violence. So here are the 3 main principles: risk, needs, and responsivity. So the risk principle says that we need to assess individuals' risk and we need to match service intensity to the level of risk. So risk tells us who to treat, and it's the higher risk individuals who are the higher priority for treatment, for getting treatment sooner, for getting more intensive treatment. And I know in Correctional Services Canada, there's different levels of domestic violence treatment offered, and who's getting the breadth of treatment, the intensity, and so on. The best available evidence-based treatment is prioritized for the highest risk individuals. In terms of sort of report card for domestic violence treatment programs, there's definitely some use of risk assessment in community programs. There's more in correctional services. And I'm taking this overview from a review by Raddatz and Wright published in 2016. There's been a couple others since with similar kind of conclusions about where we're at with domestic violence treatment. The needs principle. So the need says we need to target criminogenic needs. And criminogenic needs are risk factors that are potentially changeable, that we could change through intervention, so that if we change those needs and reduce those needs, then we can reduce the likelihood that a reoffense will occur. And there does seem to be some attention to criminogenic needs in IPV treatment, especially when it comes to substance use, which is a major criminogenic need. Although that has been controversial, we can talk about that a little bit if you like. And certainly there's treatment programs are addressing marital and family relationships as well, which is another criminogenic need. There's been less attention to the responsivity principle. So the responsivity principle has a couple of parts. One is we need to use the most effective intervention available based on the evidence base. Plus, we need to use the most effective intervention based on the individual needs, and there can be different individual needs, learning needs, cultural needs, mental health needs, and so on. So the combination of that general responsivity and the responsivity that's specific to the person in our treatment program. What tends to happen in IPV treatment is that there's sort of eclectic approach, as I mentioned, but also a one-size-fits-all approach. Some programs are able to do that combination of group level treatment and individual support as well. That gets closer to addressing the responsivity principle. So what more recent researchers have found is that treatment effects are stronger with RNR adherence. That is, the more you use the risk principle, the need principle, the responsivity principle, the greater effect that you can have from your treatment. So this study was from Travers and colleagues in 2021, and this is one of their comparisons where they're looking at people, treatment programs that on a rudimentary basis, they were doing something to assess risk, they were doing something to address criminogenic needs, they were doing something to address responsivity. What we see is that those that were the most adherent programs had a stronger effect than those that were only partially adherent or not adherent. Now, there was only one program that was completely not adherent, and that had a non-significant effect. So that overall small effect we're seeing at the bottom of the screen there reflects actually differences across programs according to how adherent they are to the RNR principles. So what does these principles look like in domestic violence treatment? I'm going to hone in on each principle now, starting with the risk principle. And I think that clinician scientists in the IPV field have applied the risk principle for quite some time. They've done it in different ways over the years. There's been a whole search for different typologies, different subgroups of mostly men, although some of this work has been done with women too, different types of individuals who use violence in different ways or have different domestic violence and criminal profiles, or have a different sort of personality in response to domestic violence. And I think that these typologies are really ways to identify the characteristics of men who are most likely to reoffend, or individuals with distinct kind of treatment needs. So this fits within the RNR principles. And there have been various typologies that identify 2 or often 3 or 4, sometimes more types of men. Examples are those with family-only violence, those with psychopathology, and those with antisocial behavior. And the general antisocial type is one that comes out through most typologies. So this is somebody who is not only assaulting their partner, maybe assaulting the children too, where there are children in the family, but they're also involved in violent or non-violent offending outside of the intimate relationship. And this general antisocial type consistently comes out as showing a relatively high risk of serious and severe and persistent IPV. And then there are typologies that have focused on the nature of violence. So there's this issue of intimate terrorism, or sometimes called patriarchal terrorism, where this is used by men to really dominate in terms of their power and control, and use a lot of coercive control in the relationship. This is associated with higher risk. And there's sort of the pattern of violence as well. People have looked at that in terms of different types. And you may have heard of what's called the cycle of violence, where there may be a violent episode followed by a honeymoon phase, followed by a building up of tension, leading to a violent event again. But in some cases, the violence seems to be more random, like no detectable pattern. And where the random violence is occurring, it seems to be associated with higher risk, again, more severe, more persistent offending. And then in terms of individuals' personality, there's been this type 1 identified, where they seem to be relatively in control when there's conflict in the relationship. When there's an argument, the person's heart rate kind of calms down rather than speeding up. They seem to be quite comfortable with the conflict. And this may also be related to the general antisocial type and the higher risk of reoffending. So these different ways of looking at typology have been really useful to look back on, I think, when we're taking the RNR approach, because we see the elements of risk being identified. We see these different treatment needs being identified, and maybe we're seeing different personality and that we need to consider when we're thinking about the responsivity principle. And then the other way of addressing the risk principle has been directly through structured balanced risk assessment. So another chat opportunity here. I'd like to know what approaches you've used for assessing violence risk in individuals, whether it's domestic violence or general violence. But then also, what domestic violence risk assessment tools or guides are you familiar with? So if you get the chance, put that in the chat, and we'll take a quick look. Okay, I'm seeing PCLR, that's great. HCR20 and DVRAG, okay. Be Safer, Patriarch, Sarah, okay, a whole range here, okay. And the Odara being in the DVRM for policing in Ontario, yes. The LS tools are great. Odara, yes, thank you. And clinical risk assessment, yes. Okay, so I'm just going to shut the chat, so I won't be able to see that so much now. But I'd like to move on and look at certain number of risk assessment tools, mostly from the two main approaches. So here down in the structured risk assessment, the two main approaches have been structured professional judgment, or SPJ, and actuarial. So the SPJ includes some that you've mentioned, the SARA, the Be Safer. These are for domestic violence here. And what they do is they've drawn risk factors from the literature, from clinical experience, and the assessor looks at those risk factors and identifies what the level of risk may be. The actuarial approach includes the Odara and the DVSIR by researchers in the US. And the items for an actuarial tool are chosen through empirical research, and the numerical risk information is interpreted. There are some ways to combine the SPJ and actuarial, and I indicated the danger assessment here, which is a tool created by Jacqueline Campbell as an interview for a woman who is being abused. And the items were developed from the literature, but tested empirically and related to levels of risk for interpretation. If you're familiar with this literature, with the systematic reviews of the risk assessment tools, you'll be aware that the average predictive effect sizes for all these tools tends to fall in what we call the area under the curve, or AUC, of 0.64 to 0.70, which is equivalent to a Cohen's d medium effect size. There are some distinctions depending on what has been looked at. Let me just see if we have more here. I just wanted to mention a couple of things, because most of the research has been done by researchers. When a systematic review has looked at what happens when these tools are used by practitioners, they're reporting general advantage for actuarial methods. And I think that's partly because they're very straightforward to use, have very clear inclusion, exclusion, and interpretation criteria. That's my opinion there. And I'm going to spend a little more time on risk assessment here, and specifically the Odara, which, as I mentioned, is a tool that I'm an author of. It was created by me and my colleagues at what's now Waypoint, and our collaborators with the Ontario Provincial Police. So this is just an overview of the 13 items that are on the Odara. The ODAR stands for the Ontario Domestic Assault Risk Assessment, and each of these items comes with an inclusion and exclusion and FAQs and all that kind of thing in the manual. But hopefully what you can see here is that the ODAR is a fairly brief tool. It identifies the risk that an individual who's used or perpetrated domestic violence will do so again. And it shows how an individual's risk compares with others who have perpetrated IPV. So it can be useful for helping identify priorities for treatment or other services. It's designed to be easy to score, and it's designed to be used from existing documentation or by police officers who are going into an incident. And it can also be used as an interview with somebody who's been victimized by domestic violence. And it can, so because it can be used across sectors, it's designed to support that community, coordinated community response to domestic violence and promote effective communication about risk across services. I'm going to give you a nutshell of how the ODAR was developed. As an empirical tool, we started with a research study where we looked at, it began with 589 men who had used domestic violence identified in police records. We followed them up for an average of nearly 5 years. And again, we were focusing on men who assaulted their female intimate partners. We identified at the time of an index assault what information could be known that could identify who was at greatest risk to go on to commit a new domestic assault. And through a series of statistical analyses, which I'm happy to share with you at length if you're interested to know, we identified those 13 unique predictors. And then each one we turned into items that could be scored as 0 if absent and 1 if present. So the total score on the ODAR ranges from 0 to 13. And then we broke those scores up into 7 different risk categories. In terms of effect sizes, so for those of you who enjoy looking at an AUC figure, this curve here, the main curve that goes across the figure, that is the area under the curve, and we had a large effect of 0.77. In our first cross-validation, we had some shrinkage, which we expect, but still a large effect with an AUC of 0.72. And meta-analyses, as I mentioned, find the average AUC for the ODAR in the range of 0.67 to 0.69. The current norms for the interpretation of the ODAR are based on what we identified as in the police records from our sample that was developed back in the 1990s. And I'm currently doing work with some colleagues to identify how to standardize the ODAR risk interpretation so that risk can mean the same thing over place, over time, and over population. The ODAR is intended to be easy to score and easy to agree on. So our inter-rater reliability has been quite good from not only research I've been involved with, but by other researchers as well. So for the total scores, our interclass correlation here ranges from 0.75 to 0.98. We've also looked at agreement on the individual items, and that's been found to be range from 69% to 100%. And we've also found good agreement among practitioners through our online training program, Odara 101, with a correlation average of 0.82. So I mentioned there are 7 risk categories. And what this figure shows is the bars show are the percent of men who we found to recidivate or commit a new domestic assault as a function of each ODARA score. And the fully shaded bars were from our construction sample. And then the partly shaded bars are from our first 3 cross-validations with similar samples. And what I hope you can see here is that the higher the ODARA score, the more men reoffended. So that's the percent recidivism on the y-axis on the left. So men with higher ODARA scores are more likely to reoffend than men with lower scores, and men with higher ODARA scores also reoffended sooner than other men and committed more severe assaults and were charged with more serious offenses, and they caused more injury to their victims. So this fits with the risk principle to ensure that men with higher scores can obtain higher priority for treatment. And we've shown different ways that treatment providers can cut down these scores based on what they're seeing in their own referral populations to identify where they can cut off those scores for the highest priority individuals for treatment. And as well as recidivism rates, this figure can show how men compare with other men using the line that goes across the bars and the y-axis on the right. So that shows the percentage of men with each category who, percentage of men in the research who fell into each ODARA category. So if we assessed a man and found that he scored 4 on the ODARA, we'd see that about 40% of men in that risk category reoffended, and that just over 10% of men in the studies fell in that risk category. The ODARA can also be used to compare women with women. So women reoffend at a much lower rate than men, maybe about 50% or less than the rate of men. So these bars would be much lower, and we don't have an interpretation table for women. But because we can see the distribution of how many women score within each score on the ODARA, then you can still compare women to women in terms of risk. Now, this figure shows the AUCs, or the effect sizes, from 18 studies of the ODARA's predictive accuracy in follow-up studies with men who perpetrated domestic violence. The small bar on the far right is from the construction sample, which I mentioned. The AUC was 0.77. And the other shaded bars show 11 published and unpublished replications by researchers that don't include me or my team. And the unshaded bars show 7 published replications by me and my colleagues. So in general, for this figure, where a study did different outcomes or looked at recidivism in different ways or had different follow-up times, I've used the overall result, or I've used the smallest result to try to not inflate the predictive accuracy that's shown here. So one thing that we can see here is, yep, on average, the effect size is falling in that medium effect size range. And another thing here is that there doesn't seem to be an allegiance effect where my research is showing the ODARA is better than other people are showing. I want to talk about just a few recent ODARA validation studies before I move on to the need principle. So here are some studies that kind of put the ODARA to new or challenging tests. So I may have mentioned that most of the research in this field is done by researchers scoring domestic violence risk assessment. Something that Jung and Hyman did recently was testing the ODARA when it was scored by the police. And they found a small effect, predictive effect of the ODARA on predicting domestic violence charges, and a medium effect for predicting domestic violence convictions, which was a significant effect. And then it's really important to do these studies to know that the risk assessment tool that you're using has been validated in the way that you're using it, or in the population where you're using it. So 2 studies have now tested the ODARA in racially diverse samples. One study that I conducted with Dana Raddatz, we were looking at a study in upstate New York, and it was a very racially diverse sample with 58% individuals who were Black, 30% who were white. And also we were pulling this from police reports. So we didn't have all the information that we needed to score the ODARA. So it was a bit of a modification of the ODARA. So we found a small but significant predictive effect. And then Hagel and colleagues looked at a sample from northern Saskatchewan that was predominantly Indigenous, and they also found a small significant predictive effect. And the effect for the Indigenous group was very similar to the effect for the total group. I think we need much more research with racially diverse samples, but these studies show that the results are promising, I think. And then we also did a study. I conducted a study with Anna Pham from her team with Sandy Jung, where we were looking at, does the ODARA work in threat assessment samples? So these are individuals who have been identified by police as particularly concerning or risky, and then more in-depth risk assessment was done by threat assessors. And we want to know if these tools, once you get an already risky population, can risk assessment tools still be effective? And we did find that the ODAR predicted IPV recidivism. We also found that it predicted any kind of violent recidivism and any criminal recidivism. These outcomes are important to look at because research has shown that domestic offenders, once at least they're identified in the criminal justice system, this is a population of men who are not just focusing on domestic violence, or not specializing in domestic violence, but engaging in a wide variety of criminal offenses. And we're not just concerned about the domestic violence when we're doing assessment, we're concerned about other outcomes as well. So now I would like to move on to talk about the need principle. So I mentioned the need principle says we need to target criminogenic needs, those risk factors that are most strongly associated with reoffending and that are potentially changeable through treatment. So here are the central 8 risk and need factors. After assessing risk, the next step is to assess the presence and the severity of each of these treatment needs. So these are drawn from research in the general offending literature. They're not specifically drawn from domestic violence, but we're trying to learn from the general literature and see what we can apply to domestic violence treatment. And there is evidence that at least some of these criminogenic needs are important to domestic violence. So drawing from that literature also, we can talk about what are some of the interventions that might be useful for these criminogenic needs. So when it comes to antisocial behavior, criminal history, of course, we can't change, but there are interventions that could aim at developing non-criminal responses to risky situations. For example, perhaps in the style of relapse prevention, but with a focus on the domestic relationship. When it comes to antisocial personality, in the past, there's been a lot of pessimism about treatment for individuals with antisocial personality disorder, but there's a growing literature on the potential for treatment, including problem solving or emotional regulation. This is being used successfully in the general offending treatment field. This could include anger management, although for various reasons, anger management has been a controversial intervention at times for domestic violence. But it would be consistent with RNR. Oh, sorry. So when it comes to antisocial cognition, so this is thoughts, behavior, ways of looking at interpreting situations and so on. And in domestic violence, this would translate into attitudes that are accepting of violence or attitudes that evaluate the violence as justifiable. So the general approach to treating cognitions regarding violent behavior comes from CBT or other techniques to support alternative thinking, or ways of looking at a situation and telling the story from a different perspective. In early attempts to treat domestic violence, the focus has been a lot on trying to change men's attitudes towards women, but also to domestic violence specifically, although there's not yet consistent evidence that attitudes about domestic violence are related to perpetrating domestic violence. So there's still more research that needs to go on there before we can have real guidance as to how to do this in treatment. Number 4 is antisocial associates. So having friends who are antisocial, being involved in gangs and so on. And this is an area where there's very little research when it comes to domestic violence. There was some work in, I think, the early 1990s that looked at what was called the male peer support hypothesis. But that hasn't yet translated into the risk assessment field or the domestic violence treatment field. So again, more research. Substance use, though, this is a widely recognized criminogenic need in both the general offending literature and also in the domestic violence treatment field. It has been controversial, again, for a number of reasons. There's concern not to be giving the person who has used domestic violence any less responsibility for their behavior. And yet at the same time, substance use is strongly associated with the risk of domestic violence, with as the proximal predictor as well. So drinking may be higher on days when there is domestic violence as well. Next is the family marital relationships, which of course is an obvious criminogenic need for people who perpetrate domestic violence, and it has been a focus of a number of treatment approaches. And both men and women who perpetrate domestic violence say that communication problems and sexual jealousy and control in the relationship, that these are problems that lead them to perpetrate domestic violence. And sexual jealousy is specifically thought of as a risk factor for intimate partner homicide. And it may be related to attachment issues that have been explored by psychologists. So methods to improve here and focus on reducing conflict and improving skills and so on. And this is similar for school or work problems. So having problems or failing to achieve or keep a job and so on is related both as a historic factor and a proximal factor to criminal offending. The research is, however, not very clear on how this relates to domestic violence, and same with the lack of pro-social recreation. Not a big, important risk factor for general offending, not really discussed for domestic violence at this point. But the approaches, if we borrow from the other literature, would be the same: enhancing performance, building skills, enhancing involvement in pro-social activities, and providing reward for the application and the effort and the participation and so on. So what do we really know about criminogenic needs among men who perpetrate domestic violence? And I've done a few studies on the need principle, mostly with Dana Raddatz here. So in this sample, we found that men who have histories of domestic violence have more criminogenic needs than other men who underwent forensic assessment. We found that for every criminogenic need that we were able to record, except for employment and school problems, for every other criminogenic need, the men who had a history of domestic violence had more criminogenic needs, in fact, or more likely to have these criminogenic needs than the other men who were assessed. We also looked at non-criminogenic needs like mental disorder, physical health problems. We did not find any group difference for these non-criminogenic needs. That's not to say these are things that we wouldn't treat for obvious reasons, but it's treating the criminogenic needs that will reduce the risk of reoffending. We also found that men who had higher ODARA scores among domestic violence perpetrators, those of higher ODARA scores, have more criminogenic needs. So this was in a routine policing sample that we did a secondary analysis on. And it looked at 5 criminogenic needs that we were able to identify in the records. So these were all men who had perpetrated domestic violence, and turns out they had at least one criminogenic need on average. And the men with more criminogenic needs had a higher risk of recidivism, as we measured by the ODARA score. So that rectangle in the middle of this table here shows the correlation between the ODARA score and criminogenic needs overall, and each of the individual criminogenic needs. And these are all highly significant correlations. And most of these criminogenic needs were also related to actual IPV recidivism, so going on to commit a new domestic assault. We also found that the ODARA is related to having more criminogenic needs overall. And this was a study where we focused on individuals who had a criminal charge for domestic violence, because we were looking at how domestic violence treatment providers could use the ODARA to prioritize individuals who were referred for treatment. And this table shows the number of criminogenic needs as a function of the ODARA score, which we divided into 3 treatment intensity categories. So we're just using these categories as an illustration for how you can identify treatment priorities. So the low treatment intensity would be a low priority for treatment. High treatment intensity category would be high priority for treatment and your most intensive available treatment. So what we found here was that on average, the men who fell into the medium treatment intensity category had about 1 criminogenic need. And those in the low category had half the number of needs, and those in the high category had twice that number of needs. So criminogenic needs increased with what we call the treatment need category, which means that you could use a tool like the ODARA to identify not only who needs treatment, but like who's going to need more assessment and intervention in terms of their criminogenic needs. Now I'm going to say a little bit about responsivity in domestic violence treatment, because there isn't, in fact, a lot of research that has been conducted on the responsivity principle. And I may have mentioned when we were looking at that, that slide that showed RNR adherence resulted in better treatment effects, and not many of the programs were actually attending to responsivity. And I've got no data on this either. So this is just a brief summary of what I think will be some of the issues in responsivity in domestic violence treatment as the field develops. First, we want to look at what are some of the risk factors in people who drop out of treatment. And what we find is that treatment attrition tends to be associated with the same kind of factors that are associated with risk for reoffending. So younger age, substance use, lower education, that kind of thing. These are risk factors for offending. They're also risk factors for dropping out of treatment, which means to attend to the responsivity principle, we need to be focusing on those people who are at risk of dropping out of treatment, because we may be losing our high-risk individuals from treatment there. Typology, I think, could also be a responsivity factor, whether we're looking at the different types of violence that people are engaging in, whether we're looking at that general antisocial personality type. I mean, these things, I think, if the typology kind of tells us different approaches to treatment. And a third issue in responsivity has to do with cultural competence. And this has been a big issue in domestic violence treatment. We need to provide treatments that are sensitive to issues such as race, culture, religion, Indigenous heritage specifically. And I know that Canada does have some programs specifically by and for Indigenous communities. I'm seeing people reappearing, and I'm keeping my eye on the time. So I was going to mention some underexplored areas, but I think we've really covered the issues in RNR and domestic violence treatment. So I'm hoping that with the things that I've looked at with risk, need, and responsivity, and how adherence improved treatment effects, and what we need to be looking at next, that I hope that you will find that we've met our learning objectives for today. In the slides that I can make available, I have a list of the studies that I was looking at, especially with respect to criminogenic needs, and a longer list of resources for those of you who want to follow up on some things. So thank you very much for being here, and I'm open to any questions.
Thank you, Dr. Hilton, for that wonderful presentation and very thought-provoking, as well as the evidence-based treatments and the literature. I think that's really useful, a very important topic. So we have a couple of questions here that quite interesting. There was a question here. I don't know if you want to comment on this. There was one question about that one of our attendees read a book on Arda Wynot's book from 2021 called Insurgent Love. And what do you think about a perspective on domestic homicide and, you know, the ultimate cause by, you know, that they mentioned? What do you, any thoughts on that question?
Mm-hmm. Thank you for the question. I haven't read the book in terms of domestic homicide. I know that a number of there's been some really good research happening recently by groups like the Canadian Domestic Homicide Prevention Initiative, and looking at situations that make especially women vulnerable to domestic homicide. One of the issues that is coming up is the use of coercive control. A lot of the research in intimate partner violence, and including in my research, has focused on the physical violence and the clear criminal offenses of assault and other violent offenses. Coercive control tends to be the non-physical means that a partner uses to keep their partner under control, to keep their partner submissive, to keep their partner afraid and unable to take the steps that they might want to take to protect themselves or to leave the relationship. Coercive control has been associated as a risk factor for domestic violence in, I think, case control studies. We need to look at this more in domestic violence generally, but it's a big issue right now because a number of jurisdictions, like in the UK and I think in Australia, coercive control is a criminal offense, and it's being considered here in Canada as well. So that's in addition to our risk assessment tools. I would say, like, we want to conduct these risk assessment tools for anybody who we're working with in this field, and those who score particularly high, we're going to be really focusing on these other issues and these situations around weapon use, weapon availability, and that kind of thing. That's what I would bring into for domestic homicide.
Okay. There's a question about, police occurrences. Do you think police occurrences is a barrier with the ODAR? Sometimes victims may never had police involved, and but there's still a significant history of physical violence.
Mm-hmm. Yeah, so often a victim is afraid to call the police, or for some reason feels that they don't want to get the police involved. What we want for the ODAR, since the question was about the ODAR, is that this could be used across sectors. So for those who are working with women who have been abused, who don't want to involve the police, we have a way of approaching the ODAR as a victim interview. And if the victim is aware of prior assaults and other things that police may not be aware of, then that can go into the scoring of the ODAR. And we have not just those bars and lines and figures that I showed you, but pie charts or icon displays and so on. That's a little more intuitive for understanding the level of risk. And what we learned from working with clinics who were providing support to women is that it's, to be able to make this tool accessible to women means that it's not just the service provider who's saying, look, you're in a dangerous situation. You're saying, based on the information you have provided me, this is the risk that your partner poses. So it's kind of giving that information back to the women and empowering them to have that information and use it to help with their safety planning and their other decisions.
Thank you. There's a question about criminogenic needs. Did you ever consider such things as low self-esteem, feelings of powerlessness as emotional drivers? Any thoughts on that?
Yes. So the work on criminogenic needs, this isn't coming from me. This is coming from people like Jim Bonta and so on in the general correctional field. Low self-esteem has not come across as one of the important risk factors that we need to be addressing as a criminogenic need. Now, I only did 3 of the RNR principles, but there's 12 or more principles that have to do with providing effective correctional service. And there are some presenting needs or problems or concerns that we're going to address regardless of whether they're a criminogenic need, okay? Because for humanitarian needs or for psychiatric health and so on. So although self-esteem is not one of the central 8 criminogenic needs, it's certainly something, low self-esteem, trauma-informed care and so on that still needs to be considered. And this can come in as a responsivity factor.
Thank you. There was a question about, can you speak about the use of DV-RAG versus ODAR?
Oh, sure. So I didn't mention the DV-RAG, but the DV-RAG is the Domestic Violence Risk Appraisal Guide, and it's an algorithm for combining scores on the ODARA with scores on the psychopathy checklist revised, which is a restricted tool. So psychologists, psychiatrists, and so on can use the PCLR. And we take weighted scores on the ODARA, so it's no longer 0 or 1, but we bring back in the item weights and a weighted score on the PCLR. Combine that, and we've got the DV-RAG. Now, the DV-RAG we tested in higher risk cases. So those cases that had a correctional history. So you've got the time or the resources or the information to be able to score more information. And we found that we could identify a group of individuals who were in the top risk category with a 100% occurrence of recidivism. So for those of you who are working in the forensic system, in the correctional system, what we recommend is that either you start with the Odara score, and then if somebody's scoring relatively high, you would take the time to score the DVRAG, or if you're scoring the Odara and the PCLR anyway, you can put them together and get something that gives you more precision at the higher ends of risk.
Thank you. There's a question about the fact that you had mentioned CBT to target thinking patterns, and they were wondering if there were other psychotherapies mentioned in the literature or in the field, anecdotally, or any other thoughts. Any thoughts on that?
Sure. There are others mentioned. I'm not like super familiar with all the different approaches that are being used, but CBT has come up quite a bit. I don't want to speak too much to that because I don't have the reviews in front of me to mention any specific measures, but I know there have been some fairly good evaluations of the Duluth model, for example, comparisons of different treatment approaches. CBT fares as well or better than some of these other approaches. I'm a CBT fan, so that's my bias, but
yeah. Sure, thank you. There's a question here about, is there any research pointing to treatment approaches for individuals with high criminogenic needs? Would they require more one-on-one or group support treatment?
I would say whatever you've got that you found to be effective, whatever is in the literature to be effective, those individuals who are higher risk get more of it. They get more group treatment if that's the evidence-based practice. If they get more one-to-one, if that's the evidence-based practice. The combination of group and one-to-one allows you to bring in those responsivity factors a little bit more. But the best treatment, the most intensive treatment, the treatment that gives you the broadest approach to targeting criminogenic needs, this is what you give to those individuals who are assessed to be higher risk.
Thank you. There was another question here a little bit early on. There was a question about, is there an instrument that you recommend for screening female to male IPV, or thoughts on that?
So honestly, there really has not been a lot of research on women who use domestic violence and assessing their risk. There is a small number of studies, but a growing number of studies with the Odara. They tend to have really small samples, and so the results have been variable. What we say is you can use the Odara to compare women to women. So supposing you're working in a correctional program that's directed for women, you can identify the highest risk individuals, the highest priority for that program among women by comparing their Odara scores, but you can't use the Odara to say, okay, you score 5, therefore this is your risk of recidivism, because the recidivism is so much lower in women than men. And we've never had a large enough sample to develop those interpretation tools for women. That is something that I'm working on right now. Sorry to not have anything more specific to say at this point.
You know, Dr. Hilton, I just wanted to thank you for this wonderful presentation. I know a lot of people are asking for your slides and stuff. We can see what we can do to connect with you to send it out to the attendees. Sure. And really thank you for that. Bernard, do you want to say a couple of words as well?
No, thank you, Dr. Hilton. Great presentation.
Thank you.
Yeah. So I want to thank everyone for attending today, and we'll hope to see you next month in Vivian Rakoff lecture. So thank you very much.